having
things up. Big time, yeah. And they won't always own up to it at first. It might be like that you start saying, oh, well, obviously we'd be thinking about, you know, that your symptoms might suggest disease X, Y, and Z, and they go, I looked it up, and one person actually, some woman said to me, she's like, I'm not stupid, I looked it up on Google before I came in.
And of course, bear in mind, this was not a general practice conference, it was medicine, but there was an interesting one about mental health for youngsters called COVE, C-O-V-E, where you can make your own music to reflect your mood. Okay, so it's something, and of course, I think youngsters are attached by their hip bones to their phones. Okay, so I think we need to use that. There are more mobile phones per head of the population in sub-Saharan Africa than in anywhere else in the world. Okay,
we're not having the conversation, and we're giving smartphones to young girls and boys for the first communion, and from a very early age they can access very dark corners of the world. Neil Gaiman said it's like the internet is like a vast library where we opened to everyone and we sent all the librarians away. There's no one, there's no curator, there's no one to tell you where to go or where not to go. It's just open.
But patients, of course, their expectations are increased by their access to information and their consideration of wider differentials than maybe we would carry with us from our medical school days. So it is a challenge to keep up to date. I'm very free about using medical sites in front of the patient.
Stuff that they've read on Google or what have you. And generally, I guess my advice is to avoid that because you will read scary stuff on the internet, and won't always necessarily be in context. And I think that's a large part of our role as GPs is educators anyway. And I suppose the more we know about technology and what's out there, the better we'll be able to advise our patients about where to go, about what to read, and about how much weight they should give whatever they read.
Not yet. I'm waiting for that to happen.
Okay.
Have you looked this up? Did you Google it? What did you find? Then at that point they'll often admit to having Googled it and got quite a scary diagnosis online that often is completely unapplicable to what's brought them in.
I think there's a huge amount of useful resources online that patients aren't aware of. So I think if we as doctors were able to inform patients a little bit better, they might be able to look after some of their own conditions.
I'd always say to people, like if you're prescribing something new, like a new medication, I always say, like, if you're going to look this up on the internet, use this website, and I suppose just remember that, like, there might be, say, like 1,000 people that are very happy with this medication and one that isn't, and it's only the one that isn't that's going to go on the internet and say, oh, I took X, Y, and Z and it was awful, whereas all the happy people won't do that.
Our focus today will be on technology and practice. Do you remember what it was like before the computer arrived?
Oh, do I what? Yeah. Now, I'm a long time computerized. I would have been there at the very beginning with the very first software package, which was even before GP Clinical. I think it was GP Care, I think. Okay. Yes, I do. And the Lloyd George files, they were called Lloyd George. They're A5 files. And
with the brain, they fit into,
Yeah, and then you had a few patients with, well, not a few, but a fair number of patients with A4 files, and they would be the more complex medical problems. I got good at summarizing them. I had a summary sheet on the front, and I suppose that was an initiation by myself and another guy who was working with me at the time, Paul Lacey, who had been trained in the UK, and so we started having summary sheets on the front of each of these files. We had them specially printed, with the details that we wanted, and that was extremely useful when we came to computerize the files, because that's a huge job, absolutely enormous job. But and I look back at them with fondness now. I occasionally will have to dig them out for a PMA or that sort of thing, and they're in storage. And sometimes if you could actually, in a few words, capture everything that was going on. And I would have inherited files from an older doctor, and he was really good at in one sentence you had the whole picture. I always remember one entry that said, arrived 2 p.m, brackets, I in the middle of my dinner, you know, a problem that's there for 7 days, and you know, you could see his anger, and then I think it was 24 and sixpence paid.
When I was a trainee in Joe Clark's practice, he was one of the few GPs who was using a computer at the time. We weren't using computerised records, but we used old Winchester drives, and we had to change drives constantly to get different applications, so you could have a word processing and an equivalent of a database program. And we used it to do referral letters, and we kept drug lists and databases on that, but we didn't have a clinical record system, and that was obviously in the DOS era, before hard drives even. So you're back now in 1990.
I suppose back in, when I came back from the UK back in the early 90s, we had worked in, myself and Siobhan, my wife, had worked in a lot of practices in the UK where computers were very much part of the scene over there. They're much more advanced than we were. Coming back to Dublin, there was very little work done on the IT side of things. So we were one of the kind of early adopters, I suppose, in general practice. We very quickly got all our manual records onto computer using a really old DOS system.
In Kinmare, South Kerry. So it's a kind of newly computerised practice. Very elderly population, mostly GMS patients. Well, I suppose number one, because I guess you're getting everyone's information in hospital. Maybe they're only getting one department's bit of information, whereas we're probably getting everyone's. And I suppose number two, because we're electronic, you don't have to sift through notes to find everything.
Yeah, in terms of technology available, it was a massive change, really. You know, you go from one extreme to the other, really. In the GP practices I've been in, you have instant access to all the patient's previous records just at the click of a finger, whereas in the hospital you had very limited access. Almost nothing was computerised. What was quite limited. Everything else would be in a chart, and if a patient had a large history, it could be based over several charts, and to find the precise bit of information you wanted could literally take half an hour.
It's just a totally different system. Like the hospital, like the computer doesn't really enter into anything in the hospital. It's all paper. It's all paper-based. The whole system is centred around paper. In general practice, like maybe 80% of the system is on computers, and the paper then is on the way out. So that's hard to know. I don't think I missed the computers in the hospitals because I never had them. But when you get to practice, yeah, I suppose it's like comparing two totally different things.
Do you see any challenges with computerization, and do you think it takes away from the doctor-patient interaction?
Oh, I've read the papers and I've seen the trainee projects studying this. I think there's a general acceptance now amongst patients. That's the person they're being interviewed by will have a computer on the desk in front of them. And you know, I've lived through the era where we tried to hide the computers and have slots in our desks, and you looked through a glass, so usually a smoky glass screen through the desk at a computer monitor that was hidden under the desk, or now with flat screens, and they're much less intrusive, of course. But I do think it's still important to try and remember that the patient is in front of you, and to try and position the computer as much as we have it here to one side, and to include it in the consultation, to be able to turn the screen so the patient can see what's on it. So I think probably globally people are getting used to that, and certainly it hasn't been an interference. I suppose initially some patients might have been a bit reticent, but in every walk of life I think we've all gotten used to screens.
I'm more or less between the patient and the screen, so it can be useful, I think, to refer to, or if you're looking up old letters or whatever and the patient would like to have a look as well. I think it's how you use it. It can be a very useful tool to just have in the background. And I think that people are getting more and more used to looking at screens and accepting that the records are all on computer now rather than the old charts.
And when you're not present, you're not hearing maybe things that you're picking up the really telling signs, or not asking the question that needs to be asked.
I find sometimes I get distracted by the screen when I'm interviewing someone, because it's right there. It's got all of these crutches on the person's history, the last however many times they've been in. You're looking for answers yourself. And I think that can be very distracting when somebody just wants to be heard.
The amount of times I hear a young person say, "He never looked at me," or "She never looked at me." They were writing notes, you know, and Or equally, I hear people say, you know, they didn't take any notes. They just listened to me. Like, it means so much. And I think if you're unsure about this, ask the young person, was this what you needed today? Tell me something I did that was good. Tell me something that didn't help.
Very often when you're in a consultation, you just have to turn away from the computer and just focus on the patients, because otherwise you're not engaged with the patient. And you know, I'm sure you know yourself, a lot of the communication is non-verbal and picking up on little things like that. And I really don't think you can get your message home to a patient if you're not facing and talking to them, and you can't really empathize with someone.
The lack of access to patient records due to computers being down, because we had that too, electricity outage, and we had no access to the patient records per se. We had a laptop that had them all on it, but it was a bit difficult.
Do you feel that the promise of technology has failed us in any way? I wanted to ask you about this because I know that you've been frustrated by communication between the practice and the hospital in the past. So what do you think?
Yeah, no, I think we are frustrated. I think it's an absolute disaster that, you know, now we have all the modes of communication and they're not being used. Trying to talk to a consultant about anything is a waste of my time and their time, because I can't find them and they can't find me, and they don't know what I'm talking about. And I find I am writing more and more letters, which is just so stupid in this day and age. They thought that health mail would sort this a bit, but a lot of the consultants don't want to buy into it, and in some ways I can understand that. But even as simple as WhatsApp, you know, where you can set up a mode of communication that can be handled when you're not, you know, that somebody can pick it up when they're not in the middle of doing something like consulting.
Yeah.
It's connectivity.
Yeah.
So, you know, in practice, we actually have what I think are pretty good practice management software systems. The electronic health record or compatible electronic health record remains the holy grail in secondary and tertiary care. So we're still a long way off actually having truly integrated solutions, though it is improving, but still really not being able to have an electronic exchange of information with specialty colleagues is a big barrier. And the other aspect from a patient point of view is actually it's so difficult for patients to actually have an accurate record of their own medical history and medications. So in the event that they're, you know, going to an outpatient's visit for the first time, in the event that they're, you know, attending an emergency department for the first time, not having ready access to their healthcare information in electronic format, I think is a big flaw in the system.
I think the lack of joined up sort of records, joined up thinking is the big thing. Now it probably is being done, but it's being done incredibly slowly. It probably will be another 10 years before we get any really good sort of joined up electronic records. And it's not because I want those electronic records to be very clever. I simply want the fact that, you know, if everything is easily accessible, then it makes life easier and makes the system a little bit more efficient.
You know, GPs at the end of the day are the pragmatists. They'll do it if it works and if it saves time and money. You know, they're not interested in it as an airy-fairy concept that's nice to have. You know, it has to work. It has to earn its keep in a way. And I think when you add value, such as with you know, electronic referrals and lab results and radiology results and all those other nice things, it makes it easy then to sell the whole concept to GPs.
In my current GP practice, they do receive an electronic discharge summary from the hospital, but again, it's very variable from site to site. I guess what I would like to see is some way to interface between the GP practice software and the hospital software systems, because I think in GP that's our great strength, and that's the value of the use of software and technology in GP, that we have all this information on a patient, their background, their drugs, their allergies, and all this information that the doctor on call at night time in the hospital needn't necessarily be able to see that at the moment, and I think that's something that definitely could be improved.
The biggest thing which has happened sort of in the last kind of year, 18 months, in my opinion, is the appointment of a Chief Information Officer in the HSE, a guy called Richard Corbridge. Richard has set up an organisation called eHealth Ireland, and they're very dynamic, and I think for once I think something may happen, and I think it's because people have realised at long last something has to happen.
One of the drawbacks has always been in Ireland the lack of unique patient identifier. I think that nut is finally looking like it's about to be cracked. So I think when that happens, and I know Richard Coleridge is a new kind of director there of ICT, you know, I think he's a guy with fire in his belly, and hopefully he'll push things along and we'll see some of the stuff that we've been looking forward to for many, many years.
I mean, some of the barriers really are legacy issues. So the fact that numerous institutions have, I suppose, their own legacy software platforms, and actually, in many ways, it would almost be easier just to try and start again and to. But you know, you have so much investment being spent on particular projects, so there's an inertia there, and actually I suppose, you know, technically extracting data from multiple systems to put into a new system is time consuming as well. And I suppose when you see the Irish healthcare system obviously is made up of numerous different agencies, so from the state to the voluntary sector, voluntary bodies, to private institutions as well, and each one of those will have, you know, its own agenda in terms of how it manages its own data. So it's often a political issue as well, that actually is a barrier to making progress.
Yeah, I think there is a place for it, and I think certain consultations will lend themselves easily to it. But I suppose for me, you can't touch the patient, and that's an important part of what we do, is actually physically examining them, whether it's even just doing their blood pressure or just putting a hand out. I think it makes a difference.
I mean, are there clinical scenarios where it's better for a patient to use video consultation if they're at work, if they're stuck at home, if there's issues around immobility? Does having rapid video access improve the quality of their care? I suppose the answer is we probably don't know at this juncture, but I'm really curious about it. The other aspect to it as well is actually from a personal point of view, and about having variety in the working day as well.
I suppose it would feel kind of risky almost if you. I think first you take off obviously the interpersonal things that go on, and you're probably going to miss out on a lot of the cues if it's just you and a screen. Then the obvious that you can't touch the patient, you can't examine them. I think personally, if I was doing it, I'd do a lot of, I think you should probably come in and see me.
I would feel that it's an enabler, it's allowing us to do more, and I think that's the real problem with it. I think because of information and because of the productivity that can come with having electronic records and a wider variety of access points, you know, email, mobile phone, as well as the traditional telephone and the computer, I would feel that our productivity as doctors is probably being pushed to the limit, and where it is almost an expectation that you can do the face-to-face consulting and the telephone consulting and the email consulting, and I think that's an expectation which can't be filled. I think if you're going to give our attention to a patient, you have to give the attention fully to the patient, whether you're on the phone or on the computer. And I have to say, I personally can see very little future for mobile phone app-based consulting, except for special situations where, you know, patients, your remote access, like in rural practices or rural Australia or places like that.
I don't think it's something that all GPs will have to get involved with. Certainly not in the immediate future. I do think, you know, certain GPs have an interest in this, and as I said, specifically there are certain cohorts and certain conditions where this might be a superior means of consultation or a more favoured means of consultation for patients. So I think it's identifying that area and, you know, providing a service for those patients. I think that's, you know, I think we're kind of obliged to do that, but I certainly don't think everybody will need to do it. I think there's huge advantages for the doctor as well for having video or distance consultations where you'd be able to interact. Yeah, exactly. So being able to, you know, a lot of GPs, especially in rural communities, they're understaffed, you know, and it's very difficult if you've got patients who are, you know, living far away and they're looking for house calls.
I think it possibly has a role in some situations, maybe where a review case, perhaps, you know, an asthmatic case, or maybe even a pill review or something like that. But I'm still old-fashioned in the sense that I like the personal interaction. I like the fact that you're sitting face-to-face with your patient, that there's room to bring up issues that maybe you didn't intend bringing up in a consultation. I think it's fine for kind of remote areas, perhaps. You know, I believe there's some telemedicine going on for the Aran Islands, with linked in with Galway Hospital and so on. So I think it has a certain role. I'm not so sure it's a general practice role, and I'm not so sure it's one that I'm looking forward to. But, you know, I think there's certainly a place for it in some situations, yeah.
Is always against the wheel. We're always fighting fires, and it makes it difficult to step back, maybe take a more holistic view of the patient at times, or particularly those with chronic diseases or at risk of unplanned hospital admissions. And actually, by changing the structure of the day, by using different means of consulting, actually gives a little bit of space, a little bit of breathing space, to think differently about how we organise our practice.
Is it a case of too much access, maybe over-medicalising a group of people? Is that a risk?
There's huge risks with it, and you know, you can make the argument that there's, at a societal level, there's huge risks already in what we do in terms of how connected we are, of, you know, how much of our own, I suppose, persona or personal information is available online.
I have very mixed feelings about it. I think it probably is going to come in, and I think maybe you're kind of foolish to try and resist it. Kind of my instinct is I don't like it. I think that kind of physical presence with the person, often, you know, if somebody's really sick, you kind of know it as soon as you clap your eyes on them, and I'm not sure that that's still there if it's done over a screen. If it's someone that you know very well, like if you were an established general practitioner and you have patients that you know, and sometimes you see them by video and sometimes you see them in person, that maybe that's a better way for it.
No, I don't think so. I think that the logic we require is still a bit too fuzzy for that. I think we're constantly trying to find solutions for patients, and particularly in general practice of all places where patients' symptoms are vague and where conditions haven't crystallized into a recognized syndrome. I think we're always going to need doctors whose main function is not to identify a specific disease, but to identify the absence of many specific diseases. And I think that's the role of the GP, as David Metcalf said, giving health back to the patient. And I think it's hard for a computer to do that. I think if you only have to look at your ECG machine, it's very hard for your ECG machine to tell you that that's a normal sinus rhythm. And
often it doesn't.
Yeah, it doesn't, and then you're left wondering, and yet it isn't really a pathology.
To date, my own feeling would be that certainly when you put in symptoms and things, it can give you suggested diagnoses, but they haven't really designed a system, to the best of my knowledge, that actually aims to give you definitive diagnosis. There's differential diagnoses generators which could be potentially useful, I think, in kind of maybe more unusual cases. But I think so much of GP is about communication and about what basically the patient's agenda. It's not really it's their time with you, you know, you're trying to serve them, and oftentimes they're not coming in for a specific set diagnosis, they're coming in for maybe some support or some advice or some information. So I guess those are things which maybe don't plug in as well to a symptoms checker as some others.
I think a computer is never going to replace some of the things that we offer. A computer is not going to be able to console a bereaved, husband or wife, or to reassure a new mother, to encourage a student who's struggling to settle. And you know, while that's not necessarily definitively the role of a doctor, it's these kind of interactions with our patients that develop the trust and rapport that allow us to have a good relationship with them going forward, and to be able to address, you know, the more relevant health problems down the line.